So, how we're checking our heart and our lungs, right? We're checking it through the imaging, and imaging can be just like chest X-ray or CT or MRI, and it is like our most informative and diagnostic method for us to read the chest and see what kind of pathologies, mostly like structural pathologies, are there. Because to check, like for example, the functional pathologies, okay, ultrasound can do that in cardiac case, but mostly we are using other like labs, or for example other maneuvers and other techniques to check our functional. And for our structural, we're using like the imaging, and imaging can be different. Here we're having mostly the chest X-rays, like the chest one X-ray, and we're having CT scan, which is also important. So to understand and let's start with the basic principles, what are important for us to understand and to read our X-ray. And we need to know several materials, and this is like we're having 5 basic densities that can be read on our chest X-ray, right? So mostly we're having like the soft tissues and dense tissues that are visible on our chest X-ray, and vice versa, like they are colored differently, and according to that color to us, right? It's just like the translucent lines are going just through the air. We don't have any kind of image for the air. It's just like the black tissue. We're having also fats, right? And fat always appears a bit lighter shade of the gray than air, because it is also soft tissue. We're having also soft tissue or fluid, and actually like soft tissue and fluid, they are having the same appearance. They are almost like blackish, and we don't have the photo of it neither, right? For example, if we're having some kind of calcium, right, for example the bones, or some kind of dense tissue like the calciogenic tissue, it usually appears like more whitish, and we will see several photos of that. If we're having some kind of metals, meaning some patient might have catheter or some kind of technical issues on the heart, it appears also a bit whitish, and we can identify the structure. For example, to see these photos, like we will discuss all the photos, here what structures you can see. Here you see the white stuff, like these ones, right? The ribs, and they are a bit whitish, right? Question? Yeah. Sure. Is it better? Okay, so as you see here, you are seeing some white stuff, right? This white. And they are all the calcium material. And air are inside the lung, and you can't see it, it's just like the black, right? Also, like you see bronchi, for example, here, these structures that are located. They are also some kind of structures, and they are giving like, as it is like the tube, and inside we're having air, that's why we're having this kind of appearance. So from this slide you should understand that we are having 5 main densities that are normally seen on the radiograph, and we should understand how to differentiate them, and according to these understandings we are able to find out what kind of structures we're having on our X-ray. Also, despite that we know that 5 structures, we also should evaluate our chest X-ray with 5 technical factors, and they are helping us to understand and adequately interpret our chest X-ray. And this is our penetration, inspiration, rotation, magnification, and angulation. So whenever we are checking the X-ray here, for example this one, we are checking what kind of structures are there by the color, and of course if everything, meaning that like the angulation, penetration, rotation, everything is clear, and we will discuss that right now. So what does they mean, right? Let's start with the penetration. Meaning that penetration means that the spine is really well visible through the heart. Inspiration means that we should see at least 8 or 9 posterior ribs. Rotation, it is like spinous processes should fall equidistantly between the medial end of the clavicles. Magnification means that we are having like really good photo of our chest X-ray, and angulation means that claviculae are normal S-shape and they are medially located, and they are medial and superimoses onto the 3rd and 4th rib. So this is our normal chest X-ray, and if you see, penetration is good, right? Why? Because we can see the spine. Okay, now check inspiration, the clavicle, and here we are able to see our spinal processes, right? This small. If you will make it bigger, you will be able to see. Another thing is that we should see magnification, and we can easily say that magnification is good because we are able to see all the lungs, right? And all the structures there. And the final is rotation. We're checking for the clavicles, and we can see that clavicles are on the same side, located like symmetrically, and it has like normal structure. So it is like, for example here, it is like the rotation is good because the C structure is really well seen, right? So based on judging on this information, we can understand if the chest X-ray was seen and taken well or not. So we are saying that like there is no technical problem while taking this chest X-ray. Okay? Do you have any kind of questions regarding this? No. Okay. So now let's discuss more in details what penetration means. So penetration means that like the X-ray adequately pass through the body parts that we want to see, and however we might not visualize everything, but we can able to see the thoracic errors which can be interpreted in this case. First one, it is like that left hemidiaphragm may not be visible on the photon field because lung base appear opaque. So meaning that either there is some kind of pneumonia or some kind of disease, or there is another problem, for example, and blood vessels are looking more prominent, and that's why we are not able to see the our spine through the heart. So what will be what we should do? For example, in the first case, when we're having, for example, left hemidiaphragm blocked, we should take the lateral chest radiograph, and based on that we will understand if it is like some underpenetrated photo or if there is some kind of pathologic processes going on. And regarding the pulmonary markings, meaning that like if the blood vessels are really prominent, that means that our patient is having like congestive heart failure. So let's see the photos of, and of course we should take the lateral fin for confirmation of the air spaces and etc. So to see here, we are having like normal chest X-ray, and we are having underpenetrated frontal chest radiograph, right? In first case, we can easily see the spine through the heart, right? Even we can count vertebrae, right? However, on the second photo, the spine, which should be like here with the black solid arrow shown, is not visible with the cardiac shadow at all, right? Also, we are checking the diaphragms. We can say that left diaphragm cannot be shown either, right? We can't see it. It should be like this, demarcated, like as we're having here. It is not well shown, meaning that we are having some kind of, for example, pneumonia process going on. Maybe we are having some kind of either fibrosis or either some kind of water in the left diaphragm corner, right? The costovertebral corner. So what we're doing in this case we are taking the lateral chest X-ray and checking the markings, and we can say if it is like underpenetrated photo or just like the pathologic process going on. Questions regarding that? No questions. What's lateral chest X-ray? Like what we've seen, it was like all the frontal chest X-ray, right? However, we're having also lateral chest X-ray, which shows us, for example, the lateral side of our chest, right? And here is our hemidiaphragm, like costovertebral angle. Here is our heart, and we are always checking if there is water or not. If there is some kind of fluid, for example, we won't have like demarcated this area. I will put like our lateral chest X-ray here because we will be discussing that also. I just really liked it. Okay. Yeah, I guess it's really easy to understand and to memorize. Yeah. Another marking means that when our picture is like over penetrated, meaning that it will be too dark and large markings will be decreased or absent at all, and we won't be able to understand like if the patient is having like some kind of pathology, for example pneumothorax or emphysema, because if you remember, if we're having, guys, it's really rude while I'm speaking and you are talking, so either you're leaving, either you are keeping. Thank you. So if you remember, we're having like the dark photo, right? And dark sign is for our air, meaning that either we're having some kind of disease where we're having lots of air inside the lung, for example our emphysema or pneumothorax, or the picture is like over penetrating, meaning that it is like still will be really dark. So what it is solution for that, we're asking radiologist and the doctor for some kind of symptoms of emphysema and pneumothorax, because in this case with the lateral films we won't be able to understand if the patient is having this kind of disease. On this picture, as you see here, we are having lots of blackish appearance, right? And meaning that like lung markings are not well seen, and this picture means it's penetrated. This is like the normal picture and you can see how it should look like. This is under penetrated and this picture is over penetrated. Okay, questions? Okay, no questions. If you remember, our next sign was inspiration. So what does inspiration? We were counting around 8 to 9 ribs, like posterior ribs on our chest X-ray, right? In the normal chest X-ray, if the penetration is really good, of course. So the fact is that like here the degree of inspiration can be assessed by that also, and we're having anterior and posterior ribs, right? Like normally we're having 1 ribs, but on our chest X-rays we are counting anterior and posterior ribs. Our anterior ribs are these ones that you see that it is connecting to our sternum, right? Do you follow my mouse? I hope you see. Like here, these ones, they are the anterior ones. However, posteriors are coming from the spinal cord, so this one, 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10, right? So that's how we are dividing on chest X-ray, like anterior and posterior ribs. And mostly we're counting our 10 posterior ribs, because on the anterior side we might have some kind of fibrosis, or we might have some kind of pathologies, and it's a bit hard to differentiate it with pathologies. So it's better to count our posterior ribs to know that these are truly ribs, because they are coming from the vertebrae, right? If we want to know if the patient is having excellent breathing inspiration or not, we should calculate around 10 posterior ribs. If we're having some kind of hospitalized patient, then we are mostly visualizing around 8 to 9 posterior ribs. It also depends on the degree of inspiration we're having. And yeah, so according to this knowledge, we can have two diseases, right? Either poor inspiration or either extra good inspiration. When we're having poor inspiration, meaning that our lungs will be more compressed, and we will have more crowded lung markings, and especially the basis of lung, and the number of the ribs that we're calculating will be less. Yeah. What we should do in suboptimal inspiration, we can calculate around 8 ribs. Yeah, for example, 1, 2, 3, 4, 5, 6, 7, and 8 ribs here. We are always calculating the back posterior ribs. As you see here, the photo is not really clear, right? So we should check always for our lateral chest radiograph to see if the patient is having pneumonia or not, or what disease he is having that we can't calculate the ribs. So these are the key points to differentiate anterior and posterior ribs, and why we're calculating. Posterior ribs are immediately more apparent to the eyes than the anterior ribs. Posterior ribs location is less horizontal. Also, all of the ribs are attached to our vertebra, right? To the thoracic vertebra. So we will exactly know that this is our rib and not any other structure. Anterior ribs are also visible, but if there is some kind of pathology, and if we're having some kind of, for example, heart diseases like this, it would be a bit harder for us to calculate the anterior ribs, and that's why we are not calculating them mostly. Also, anterior ribs are located more downwards towards the feet, and also anterior ribs are attaching to the sternum on both of the sides with the cartilage, and sometimes later in life the cartilage can't be visible, so in earlier life it can't be visible, or in later life it is cartilage is more calcified, so in later life it is visible. So if we are taking the chest X-ray of our child or baby, it won't be able for example, see our anterior ribs, because cartilage won't be visible. Questions regarding this? No. Okay. Another key point that we are having, it is our rotation. So, do you remember what rotation meant? Okay. I will read once more time what rotation means out loud, officially, you to remember, because these are really good questions to ask you guys. So you should know the definitions really well. Rotation, it is when spinous processes should fall, a patient should stand symmetrically on both sides. If there is no symmetrical location of the patient, we are having some kind of rotation, right? So meaning that one structure or another structure might seem more or less, and this gives us like great pathologies, like we will think that the patient is having pathology. So that's why when we're having some kind of rotation, it is altering our contours of the heart, great vessels, our hilum or hemidiaphragms, and we might think that there is some kind of disease. How to check if the patient is standing still or not, and if he is standing like symmetrically, we are checking our clavicle related to the spinous processes, right? So the medial ends of the clavicles, as you know, are anterior structures, and spinous processes, as you know, are our posterior structures, right? So here we're having like several ideas how the patients can be standing, right? So for example, if the spinous processes appear to lie equidistant from the medial ends of each clavicle on the frontal chest radiograph, means that there is no rotation at all. In this case, for example, or in this case, as you see here, like it's a bit over penetrated photo, I guess, but like at least we are able to see the spinous processes and clavicles really well. And here you see our clavicle right here and here, and you see the spinous processes are in between of our clavicles really well seen, right? It is like distance between the clavicles and spinal processes are symmetrical. Okay. If the spinous processes appear closer to the medial end of the clavicle, the patient is rotated towards his or her own right side. So in this case, this one, so the patient is rotated to its own right side, and as you see here, it is towards the medial right. And the third one, for example, if the spinous processes appeared closer to the medial end of the right clavicle on this side, and meaning that patient is rotated towards his left side, like this photo is showing us. Okay. So what pathologies we can have in this case if the patient is rotated really badly and we have not checked his rotation, meaning that like hilum may appear larger as we are rotating further away, and we should do what we should do. Again, we're having the help of our lateral chest X-ray, and we should confirm the enlargement of chest X-ray through the lateral view. Another thing is that also when we're having rotation, it may also disorient our like normal heart contours, and we might think that heart is even bigger or smaller, or great vessels is bigger or smaller. Also, hemidiaphragms may appear higher or lower, mostly depending on that, and we might think that there is some kind of, for example, liver pathology. Like as you see here, we're having severe rotation in this chest X-ray, and how you can check that there is severe rotation, you see like this clavicle, it's more frontal and it is like more backwards, right? So the clavicles are not standing on its normal location. This hemidiaphragm is also like upright position because of that, and the heart is not on the normal location, right? It is on the right side of the lung, and it's not their location, it should be on the left side. So that's why we can say that it is like severe disoriented, and orientation is really altered regarding that. Questions regarding this? No. Another thing that we should check always is our magnification. Magnification, do you remember what it meant? Okay, one more time to memorize what magnification it is. It is like how we are magnifying the structures that are located in anterior posterior films mostly. So, regarding the magnification, normally it's like not issue for our pulmonary anatomy, because patient's position is more important for the this. However, like magnification is really important for our heart size and heart pathologies. So the idea here is that the closer we are having the object, more huge and more enormous it will be seen, right, than actual size. So we always should check the location of the subject that appears in front of us, right? So when we are watching on the posterior anterior projection, the heart, like we are having three types of the chest X-rays. We are having like lateral from the side, we're having anterior posterior from that picture is taken from the anterior side, and we are having posterior anterior, meaning that picture is taken from our posterior side, right? As the heart, or normally it's our anterior structure, when we're taking posterior anterior projection, we should like go a bit closer to see the structure really well, right? Vice versa, when we are having the anterior posterior projection, for example, the heart is farther from the imaging cassettes, therefore we are having slightly magnified. So therefore, a heart can appear slightly larger on anterior posterior imaging, and vice versa, a bit smaller than on the posterior arterial imaging. That's all like according to from where which angle we are taking the photo. So we also know the inches that we should take from which spot we should take the photo. For example, the distance between the X-ray tube and the patient is shorter when we're taking anterior posterior image, and it's around 40 inches. And when we're taking posterior arterial anterior image, we are having around 72 inches to take and have the normal chest X-ray. In this case, we're having like the two different photos, and we see that different sizes, different inches from where it was taken, right? So for example, A photo is like magnified more than B photo. I'm talking about heart, and you can clearly see the lengths right here and here. So we can say on A photo there is like more magnification and heart is more closer than on picture B. However, if the standards are not taken, everything is not taken by standards, we might think that there is some kind of heart pathology. So it really matters what kind of radiologist is taking it, and if there is any kind of technical problem. And angulation, it's one of our final parts that we are taking photo of, and we are checking because like the angulation means like the how our clavicles are located and where they are located, for example. And also like if we are checking if our thorax is located on perpendicular or horizontal areas, because we are having changes and changes like rotation on our X-ray. For example, if the patient is standing on our perpendicular plane, meaning that X-ray beams, all of the beams are going on the straight line, right? And on the like normally. However, if we are taking the horizontal, patient is lying horizontally, meaning that like the X-ray beams are not going the same length to all the chest structures, right? So meaning that in that case we will have anterior structure more higher projection than the posterior structures. So this is like our erect chest, apical lordotic view, and we're having like a semi-recumbent chest, right? So as you see here, we're in erect position, we're having all light going to the straight line together, and all of them are going same size beams are going to the chest, so the picture will be really well. In apical lordotic view, what I mentioned, we're having mostly like the anterior part chest visible really well. And when we're having semi-recumbent chest X-ray, meaning that mostly like middle and posterior parts will be better seen, right? Also, like according to that, we can understand what kind of pictures we will have, right? Some of the structures will be visible well, and some of the structures won't be visible well. So, for example, in the apical lordotic view, as we're having, and as we are magnificently the anterior parts, meaning our hemidiaphragms, might be lost at all, and vice versa. If we are seeing like semi-recumbent chest X-ray, meaning hemidiaphragm part will be seen really well. However, the upper part won't be seen at all, right? Really well. So here we're having like apical lordotic chest X-ray, and this is like more visible than semi-recumbent position for us. And as we say, if you want to see apical part, we see it really well, right? Because like as you see, we see the clavicle S shape really well, right? And also like if we're having some kind of heart, if we want to check the heart shape itself really well, we can see it here, for example, with the apical lordotic position. Okay. Questions still here? No? Repeat the last thing? Sure. From here or from here? This one? So, meaning that I was talking about apical lordotic chest radiograph, and I was saying that as you see, we are having more beam going on the apical side, and that's why we see really well our clavicle S shape, right? In the normal chest X-ray, we won't see that well demarcated our clavicles, for example, here or here, right? That's why also